Injury, we have two main types of cellular injury. The reversible type, where the cell can go back to its normal status after the incident has gone, or the irreversible cell injury, where the cell can never go back to its original status. So, for the reversible cell injury, there is a reduced amount of ATP, which means a reduced amount of activity of the calcium and sodium potassium pumps. So pumps means that they do require ATP, and since we have like less ATP than expected, then we have less activity of these pumps, leading to cellular swelling. So that swelling includes cytosol, mitochondria, endoplasmic reticulum, and Golgi apparatus. Basically, this is the earliest morphological manifestation of a cellular injury that we can see. That's followed by ribosomal polysomal detachment, which reduces the protein synthesis. So if we take a look at the image over here, then this is the normal cell, and of course it has the nucleus within, and then nucleoli, and then the chromatin over here with Golgi apparatus over here with the ribosomes attached to it, and then the mitochondria and everything. So the first step is this green color is reversible. That's why it's two-sided arrow. That's which means it can go into from normal to swelling and then go back to normal. Basically what happens is like there is cellular swelling. We can tell that that these organelles are getting bigger in size, plus like the ribosomes that were attached over here are getting detached, so they just are not attached to the Golgi apparatus anymore. Plus the membrane, like the outside membrane of the cell, gets this blubbing, that's out poaching, plus nuclear chromatin clumping. So the nuclear material is not just connected to every other part like it's supposed to be under normal status. Now it gets this clumping like into these different portions, but still all of this is just reversible and can go back to its normal status. So just um, what happens in addition to all the things that we said of the image, it says over here that there's plasma membrane changes, like we said, blipping, nuclear changes like chromatin clumping. There's rapid loss of function as, well, of course, as long as the cell is not normal, it's just getting this weird swelling, then of course it does not function as it's supposed to be functioning. Just for as an example of the loss of function is myocardial cells being non-contractile after 1 to 2 minutes of ischemia. So if a myocardial cell gets ischemia, that's reduced a blood supply to that cell. Within 1 to 2 minutes of that loss of oxygen supply, the blood supply, it will be non-contractile, so it does not contract. That's why it's rapid, so within like 1 to 2 minutes for the myocardial cells. Also, we could see the myelin figures. These are the aggregations of peroxide lipids. So we know that within every cell, we may have some lipids, and they are formed under different conditions and in different shapes. So in the reversible cell injury, they would be peroxidized, and that's when we call them myelin figures. Okay, so from now on, if that like the cellular injury keeps happening, it gets to the part where it does not go back to its normal state anymore. There's no way it can go back to its normal status. So that's the irreversible cell injury. What happens is there's a breakdown of plasma membrane, as we can see over here, that the plasma membrane is just not continuous as it's supposed to be, which means it's breaking, so it's leaking to the outside. That leads to cytolic enzymes. Cytolic enzymes, just like troponin, leaks to the outside of the cell. Plus, there is an influx of calcium leading to activation of degradative enzymes. So, whatever like enzymes within the cell, just like the enzymes that were supposed to be here over here in this enclosed lysosomes, now these lysosomes are going to rupture, like they're going to be open to the outside, so they're leaking. And of course the cellular membrane is not intact anymore, so they're leaking to the outside. Just as we see when a patient gets myocardial infarction or like a death of myocardial myocyte, um, uh, the patient will have like increased levels of troponin. Um, So that's one example about it. The other examples is just like whatever the contents of the lysosomes going to the outside of the cell, and we can actually check it, um, like increased levels of these enzymes within the serum of the patient. So this leakage also, because the cell wall is not functioning as it's supposed to be, there would be an increased influx of calcium to the inside, and that also by itself leads to an activation of degradative enzymes. These enzymes are just going to, finish up all of the work of the cell. So it's just going to degrade the cell. One more thing that happens is mitochondrial damage and dysfunction, and that is the mitochondria over here, because it has already gotten even bigger now. It increases its permeability, so it allows things inside and outside that it normally should not allow. That's why it increases mitochondrial permeability, which leads to loss of electron transport chain. So basically, electron transport chain is one of the main um, functions that the mitochondria can do, is that they do like this process of transporting electrons to generate energy to do the metabolism stuff, and that's related to the biochemistry. So if we lose the electron transport chain, which is supposed to happen in the mitochondria, that means a decreased level of ATP. And we know if we have decreased level of ATP, that's really bad, because that means like the body is unable to function, like the cellular on the cellular level. Cellular components of the body are just not functioning as they're supposed to, and that's a huge problem. So at the end, there is rupture of lysosomes, as we said over here. So because lysosomes have these specific enzymes that do degrade things and they rupture on their own, this is why it's called autolysis. So it's not like something from the outside causing them to lyse and undergo degradation, but it's just they by themselves, because the cell, like the main cell, has really gotten too big, or the incident is just too harsh, they would go into auto lysis. So one more thing, that is the nuclear degradation, and it could be like on different levels. So first of all is pycnosis, and there's only nuclear condensation, like the nuclear material over here could just condense instead of being its original state, like it's really nice uh, thing over here. It gets really condensed. That's when we call it pycnosis. Or it could even get worse, and it happens as nuclear fragmentation caused by endonuclease mediated cleavage. Or like these condensed nuclear material is going to be cleaved by like endonuclease. So everything that ends with ASE basically is an enzyme, and these enzymes usually degrade. So the degradation that is maintained or mediated by the endonucleases is going to lead um, to nuclear fragmentation. So they're going to be like small fragments of the chromatin material. So that's called karyohexes. Karyohexes. Um, Finally, like the worst part of it is karyolysis, is when all of this nuclear material dissolve, like there's nuclear dissolution. So they go away, they just disappear, like from these tiny clusters into absolute disappearance. Uh, the very last thing to see over here is the amorphous densities or inclusions in mitochondria. So the mitochondria is just going to have multiple levels of either like too dense or just too light inclusions within the mitochondria. That's why there are amorphous densities or inclusions in the mitochondria. So that's for page 203. For page 204, it is going to be talking about the apoptosis. It is an ATP dependent, so it requires energy, programmed cell death. So the key point over here is that it's a programmed. So it's like the body has decided intentionally to kill that cell. So the body has decided intentionally to end the life of that cell. That's why it's something that we do program. It's not like because of because of something that we did not expect. So that's the very main important thing about it. It's just because the body is requiring to do this process in order to organize the contents of the body. So it could be, of course, even though it's a programmed, even though it's decided, but still it happens for multiple reasons or through multiple pathways. For example, like an intrinsic factor could affect, that is something within, okay? So something from within the cell causing it to undergo programmed death, or some extrinsic factor, something from the outside affecting the cell leading to its death. And of course, there could be perforins or some kind of enzymes that do degrade the cell, leading to its programmed cell death. It could be intrinsic, extrinsic, and perforating granzyme B pathways. All of these are pathways lead up to the main end result, that is the apoptosis, that is the programmed cell death. It activates capsaces. So capsa caspases, yeah, nice. Caspases. These caspases are cytosolic proteases, and as we said, because we have this ASE, it's an enzyme, and basically it's degrading the contents of the cell. And these enzymes usually are found in the cytosol of the cell. So collectively, their name is called caspases. So they are activated through these pathways, whether it's intrinsic, extrinsic, or perforins or granzyme B pathways. Oh, these caspases end up killing the cell, causing cellular breakdown, which includes, of course, cell shrinkage, chromatin condensation, membrane plopping, and formation of apoptotic bodies, which are then phagocytosed. So these are the multiple steps that the cell undergo when it's undergoing apoptosis. So first it goes into shrinkage, like it gets reduced in the size, and then the chromatin material, that's the genetic material within, is just going to be condensed even more. Of course, and the membrane blopping, that is, the outpoaching of the membrane in this kind of weird circular way, with formation of apoptotic bodies. So as an end result of all of that, that is going to be phagocytosed. So the phagocytes are going to come to this uh, dead cell and eat it up, like separate it into parts and then just eats that cellular debris. This process of apoptosis is characterized by deeply eosinophilic cytoplasm and basophilic nucleus, pycnosis, and karyohexes. So if you want to take a look under the microscope and see like what is what are the findings that do say that this cell is just not alive, it's going under programmed cell death. Basically, we see an eosinophilic cytoplasm plus a basophilic nucleus. So there is like a difference. The nucleus would be basophilic, while the cytoplasm, that's eosinophilic. For the genetic material or the chromatin, it could be pycnosis or karyohexes, and these are the two the very worst stages that the chromatin material can get to. That's the karyohexes and karyolysis. In the meantime, cell membrane typically remain intact. Why is that? Because it's programmed. Even though we're trying to kill the cell, but that's within boundaries. We just don't want to kill it, and it goes on its way. It just programmed. So there should be some kind of cell membrane or some kind of a thing that contains the cellular debris without significant inflammation, because we already have programmed for that death. So that's why this is the main key point over here. It's a programmed. Just unlike necrosis. Necrosis is unprogrammed cellular death. That's why in necrosis we can see like significant inflammation, like the body gets into this alarmed state of, the cells are dying and everything. But under apoptosis, no, we don't undergo that. Um, One of the other things that we can see in apoptosis is DNA laddering. that's fragments in multiplies of 180 base pairs. So the DNA laddering is just like cutting off the DNA in a way that we can like see pieces of 180 of two pieces of 280s, three pieces of 300 180s. So it's multiplies of the number 180 base pair. It is This is of course a sensitive indicator of apoptosis. So if we see that, then basically this cell is of course going under apoptosis. That is the DNA laddering. The very first pathway for the cell to undergo apoptosis is the intrinsic or the mitochondrial. So the intrinsic is the mitochondrial, the same thing. It's involved in tissue remodeling in embryogenesis. So we know that the embryo is going under a lot of development, and a lot of things are just not required anymore, and they need to go away so the baby can get its final shape. That's why we use the intrinsic or mitochondrial pathway. So the mitochondria from within the cell, this is mitochondria from within the cell, decide that is going to end up the cell and undergo apoptosis. So we mentioned that that happens in embryogenesis. It occurs when a regulating factor is withdrawn from a proliferating cell population. So what happens with this time is usually when the cells try to multiply or undergo like development, like these areas are going, it's development, there is a regulator or there is a factor that's causing these cells to undergo development. If this factor is not there anymore, like the one factor that is encouraging these cells to undergo like proliferation, if it goes away, then these cells are just left back alone. So they just don't um, undergo proliferation anymore, and they end up undergoing apoptosis because they're not encouraged to proliferate anymore. So, for example, that's decreasing the interleukin 2, that's a cytokine, after completed immunologic reaction. Let's see, or let's say that we do have an immunologic reaction for any kind of reason, and at some point decide that that's it, we don't need this immunologic reaction anymore. So we don't produce interleukin 2 anymore, or we don't send interleukin 2 to that specific place. So interleukin 2 is not going to keep activating the immunological reaction. That's why cells undergo apoptosis of the proliferating effector cells, of these cells that we were asking them to work and do the job for the immunologic reaction. It also occurs after exposure to injurious stimuli, um, just like in radiation or toxins or hypoxia. So if the cell undergoes radiation, toxins from, let's say, bacteria or virus, or if it goes under hypoxia, some stress conditions, that will also activate the intrinsic or mitochondrial pathway. It is regulated by BCL2 family of proteins. This is, as the name implies, it's a family of proteins, so it has multiple subtypes. So some of these subtypes are just like BAX and BAC proteins. They are pro-apoptotic. So pro-apoptotics, that's something that, you know, um, that is there before the apoptosis starts, okay? While the BAD, that is for survival of the cell. While the BCL2 and BCLXL are anti-apoptotic. For memorization, uh, whenever it's a BA, just like backs or back, basically it's bad. So it means it's going to kill the cell, even though it's a program. This is just for memorization. Like these are pro-apoptotic stuff. So they're going to kill the cell. While whatever thing that starts with CL, like BCL2 or BCLXL, that's anti-apoptotic. That does not allow the cell to undergo apoptosis. So the cell just stays alive. That's why it says be clever. Just for memorization. We also have the backs and back from pores in the mitochondrial membrane. Well, these two proteins that are pro-apoptotic, they do so by forming pores, like openings in the mitochondrial membrane. So they go to the mitochondria, whatever the mitochondria is. So this is the mitochondria, okay? And these are the backs and back proteins. They cause these perforations over here. And of course, perforations are just like outlets. These outlets would lead to release of cytochrome C from inner mitochondrial membrane. Um, because now this mitochondria, this nice, perfect mitochondria, is going to have these openings, these pores, is going to release this cytochrome C from within the cellular membrane. Um, into the cytoplasm, of course, because the mitochondria exists within cytoplasm, so of course it's going to release its content to the cytoplasm. That would lead to the activation of caspases. So cytochrome C coming out from the mitochondria into the cytoplasm would lead as an end result to the activation of caspases. And we already talked about caspases, is that they are some cytosolic proteases that do kill and degrade the cell components. For the BCL2, it keeps the mitochondrial membrane impermeable, thereby preventing cytochrome C release. Uh, well, we talked about BCL2 and BCL-XL are being clever and trying to keep the cell alive and everything. They do so by protecting the mitochondrial membrane, by not allowing this mitochondria to have pores within. No, that's not allowed. And if they don't have pores within, we don't have cytochrome C going from the mitochondria to the outside. Um, the BCL2 overexpression, for example, if like one example that we have a lot of BCL2 more than we need is just like follicular lymphoma. That's when we have translocation of 14, 18 chromosomes between like the 14, 18 chromosomes. That would lead, of course, to decreased caspase activation. And makes sense. We are not allowing the cytochrome C to go outside, so we are not allowing the caspases to work. That's why we have tumorigenesis. So we are not allowing the cell to undergo programmed death. So they just don't die. And that means a lot of cells ending up creating a tumor. So that's the basic idea behind tumorigenesis. Let's see, that's for the intrinsic factor. That's when the mitochondria starts the whole thing. Well, the extrinsic factor, that is the death receptor pathway. And I think it's clear from the name, because basically a death receptor is like some receptors from like going from outside of the cell and getting some signals from the outside effectors to kill that cell. It's a ligand receptor interaction. So basically the cell that is going to die just has some kind of receptor overall, and there is some new ligand coming from somewhere else leading to its death. So over here, the example that is mentioned is FAS-L binding to FAS, and that's FAS actually. It's CD95, or tumor necrosis alpha binding to its receptor. So we have two examples. That's one receptor that is called FAS, and what binds to it is the FASL. That's the FAS ligand. And by the way, the FAS ligand is coming from cytotoxic T cells. And we know that cytotoxic T cells usually are going to kill. So they send their nice ligand to attach to the receptor on that cell that we are willing to kill, and that would lead to the activation of caspases over here. And we know what caspases do? They do cytoskeleton dispersion and nuclear fragmentation in cytoplasmic plopping, and the cell undergoes dying. So that's one example. The second example of the death receptor is the tumor necrosis factor alpha, and that is a cytokine. It attaches to the new tumor necrosis factor alpha on the cell, like receptor on the cell, and this cell is just like the FAS. It's called death receptor because they do receive some death signals from the outside. Um, so the fast and facile interaction is necessary. When is this part required, or when do we see that part usually and important? It's in thymic medullary negative selection. So we know that in the immunity system, immunological system actually, it's we do have the thymus that is you know um, in the center of the chest of the baby usually, and it has like multiple, this is the thymus, and it has like multiple levels from within, and the lymphocytes undergo development from the outside to the inside usually. So we do have some checkpoints all over the thymus. Okay, so we are checking, are these cells undergoing positive selection, which means we are choosing them to survive and go fight infection, or are they just going undergoing some inhibition or negative selection, which means they are not allowed to go and fight infection. So this negative selection, that's the decision of not allowing the cell to undergo like proliferation in the thymus, in the thymic medullary negative selection, that is related to the FAS and FAS-L. So that happens because the cytotoxic T cell decides, no, I don't need you. So it just sends its FAS-L ligand to that cell's FAS receptor and causes it to die. Um, well, an example of that is just the autoimmune lymphoproliferative syndrome. It's caused by a defective FAS-FAS-L interaction. So if we do have a problem, ouch, let's say that we do have a problem with the interaction between this ligand to this receptor, what is that going to do? That is going to cause the autoimmune lymphoproliferative syndrome. It's a failure of clonal deletion. So we are unable to delete those cells. So we are unable to kill them. That means we increase their numbers. So of course, these are lymphocytes or like immunological cells, and we know these cells do self-react. So like they do react or interact between each other, and that would present with lymphadenopathy, like enlarged lymph nodes and everything, with hepatosplenomegaly, with autoimmune cytopenias, like an overall decreased reduction of the cells that we need to have. So this misarrangement or disorganization leads to the autoimmune lymphoproliferative syndrome. And the main cause was there is no nice interaction between the FAS-L and FAS ligand. That leads to autoimmune lymphoproliferative syndrome. One more thing is one more pathway of killing these cells is the perforin slash granzyme B pathway. It's a release of granules containing perforins and granzyme B by immune cells, just like cytotoxic T cells and natural killer cells, leading to perforin forms a pore for granzyme B to enter the target cell. Basically, it's some other immunological cell, just like cytotoxic T cell or natural killer cell, okay? They decide that they want to kill this cell. So what they usually do is that they send their contents, like some granules containing either perforin or granzyme B or both. They send it as we see here. So this is cytotoxic T cell sending its perforin slash granzyme B pathway to the some to the perforins that were created on the target cell, leading to its death. How does it end up dying? It just because it goes activate the caspases, and the caspases, do every other uh, step of killing the cell. So the perforins form pores. Like as the name implies, it just um, creating pores in the wall of the cell, allowing it to have these granzymes B, or the enzymes that are going to kill it. So that's talking about the target cell. So one more thing to know about this part is after this cell undergoes dying and killing, it just end up being in small parts, like small chunks. These small chunks have these macrophage receptors, and these receptors would go and attach to their own places that are existing on the macrophages. So this is a macrophage, which means the macrophage is now able to surround this cell and just eat it. That's why we don't have debris. That's why we don't have a lot of inflammation, because it is programmed, okay? And it's because the macrophages eventually is going to eat up all of the mess that has occurred in the apoptosis. So again, the most important part is an ATP dependent programmed cell death, which leads to the other name that is necrosis. And of course, it is enzymatic degradation and protein denaturation intracellular, it killing of the cell, leading to local inflammatory reaction, just not like apoptosis. So necrosis is unprogrammed, okay? Necrosis leads up or ends up with a lot of mess, okay? It's not contained, it's not clean, it's not nice, it's just something that we didn't think about too much, okay? And mainly it happens because of exogenous injury, because if it was within the body, then it would be apoptosis because we're fine, we're controlling everything. But if we do have some exogenous signal, then it would lead to plasma membrane damage. It would lead to cell undergoing enzymatic degradation and protein denaturation with intracellular components leaking to the outside. And that leads to local inflammation, not like apoptosis. So we have like five, actually six types of necrosis, depending on their site. Right, where is that necrosis happening? For example, for the coagulative necrosis, it is seen in ischemia or in fracts in most tissues except for the brain. Okay, so in ischemia or in fracts where there is a reduced blood supply to a specific organ or specific tissue, we may see the coagulative necrosis. That happens in most tissues except for the brain. We don't see coagulative necrosis within the brain. Okay, the reason for that is ischemia or infraction. Injury denatures enzymes. So the injury leading to these enzymes being denatured, and we know when enzymes are disrupted, they're undergoing a proteolysis blocked. So the proteolysis is not working anymore, so it's not really neat and clean as it's supposed to be, as in the apoptosis. So this proteolysis is not going to work in the perfect way, let's say. Okay, the histology, if we do some biopsy and check out that tissue, we can see preserved cellular architecture, like cell outlines are seen. So there, some of them are going to have some original shape of the cell, some of them are not. For the coagulative necrosis, we do see preserved cell architecture, so the cell outlines are seen, but the nuclei disappear. We don't see nuclei anymore. There is an increased cytoplasmic binding of eosine stain. Usually, the cytoplasmic stain eosine that perfectly, but now we have that increased capability of binding eosine stain, leading to increased eosinophilia, and that's, the eosine is just the red pink color, and that is image A. So there you go, a red pink color of eosine stain. The second type is the liquefactive necrosis. It's seen in bacterial abscesses, like abscess due to bacteria, not viral, not helminth, not something, it's just bacterial. And also liquefactive we can see in CNS infracts, that's the central nervous system. It happens due to neutrophil release, like lysosomal enzymes. We know that neutrophils usually have these enzymes within. They're called lysosomal enzymes that usually digest tissue when needed. But what happens in liquefactive, they undergo this uncontrolled lysosomal enzymes digestion. So that's the liquefactive necrosis. The early signs of liquefactive necrosis are just cellular debris and macrophages, because we know the macrophages usually come to eat the cellular debris. While in the late manifestations, like lately after that, we can see some cystic spaces and cavitation. That's in the central nervous system. So because it's like factor necrosis, some cysts, like cystic spaces, actually not like actual cysts, but like spaces that are not filled with the regular tissue are going to exist. So cystic spaces and cavitations in the CNS, and that's image B. And there you go. This is a cystic um, um, degradation or cystic space. Um, One of the other things is that neutrophil and cell debris seen with bacterial infection. As we said, this is due to bacterial infection. So neutrophils are really activated like to a very high limit when there is a bacterial infection. For the caseous necrosis we can see in TB, that's tuberculosis, or systemic fungi, just like histoplasma or capsulatum or nocardia. So all of these, um, they usually end up having caseous necrosis of the tissue. So it's due to macrophages this time. Macrophages wall off the infectious microorganism, causing granular debris. So the macrophages, their role in this one is they actually surround the infected microorganism. So they surround like the fungi, okay, in order not to let that debris or that necrosis go away. So eventually, that would lead to cellular debris, but being in granules, like contained within specific uh, um, structures, not like going all over the body. Okay, that's for caseous. The histology is fragmented cells and debris surrounded by lymphocytes and macrophages. Um, that's why it's called granuloma. So that's the explanation for granuloma. It's some fragmented cells and debris, which is expected in necrosis, but it is surrounded by lymphocytes and macrophages. And it looks like cheese. So yeah, the name kind of looks similar. Caseous cheese like gross appearance. Yeah, no, somehow. Anyway, so for the appearance, it's as in C, and there you go, kind of looking like a cheese. Um, that's for gross appearance, like when you look with the naked eye. With the naked eye. Okay. So for fats necrosis, it's an enzymatic. Okay. So fat necrosis basically is happening due to enzymes overreacting. Just like in acute pancreatitis, we know that the pancreas has so many enzymes. So in acute pancreatitis, of course, the region will be enzymatic. That's why it looks fatty. So there's saponification of peripancreatic tissue. Saponification of peripancreatic tissue. It's not just like within the pancreas, it's just surrounding the pancreas. Or it could be non-enzymatic, just like traumatics, okay? Like injury to breast tissue. So it would also end up being fatty necrosis, but this time the problem was not related to the enzyme, it's related to a trauma, just like injury to breast tissue. It is due to damaged pancreatic cells release lipase. Well, the enzymatic cells, the pancreatic cells do have lipase, and when they do release it, it's an enzyme that breaks down things. So, usually breaks down triglycerides, okay, leading to liberated fatty acids. And these fatty acids are not just going to stay there as fatty acids, they're going to bind calcium. That calcium plus fatty acids, that's the saponification. That's the chalky white appearance. That's why it looks um, white, just like a chalk. And that is image D. And voila, there we go. In the outline, well, the histology, it outlines the dead fat cells within peripheral nuclei, without peripheral nuclei. So what we see is that like dead fatty cells, and these fatty cells usually don't have the peripheral nuclei, like they don't have the nuclei to the peripheries of the cells. That's how we know that they are fat cells. So saponification of fat combined with calcium, as we said that fatty acids bind calcium, it appears dark under blue Chinese stain. Okay, that's why. Well, that means that was the wrong thing to talk about. This is the dark color. This is a dark color. This is basically a dark color. So it's just that it looks dark blue, dark blue on a Chinese stain. So that was the fatty necrosis. Okay. For the fibrinoid necrosis, it's an immune vascular reaction. That's PAN. Um, it could be immune vascular reaction or it could be non-immune vascular reaction. One of two, either immunity dependent or immunity independent. But basically, it's still vascular reaction. So it could be hypertensive emergency or preeclampsia. Okay, that is like a pregnant female having a very high blood pressure and some other symptoms. That is really bad, and it should not get to be eclampsia because that's really bad. So that's the fibrinoid. If it's a vascular tissue, then it's a fibrinoid. It could be either immune or non-immune reaction. It's due to immune complex deposition. That's some kind of hypersensitivity. That's type 3 hypersensitivity, when the antibody and the antigen both like attach together and they deposit in the tissue. So that's one, immune complex deposition and or plasma proteins, just like fibrin leakage from the vessels, because this happens in the vascular wall. So the vessels are not gonna stay intact. They're gonna break down, and if they do break down, they would allow the leakage of some contents of the vessel, and some of the contents is fibrin. So these are some plasma proteins, for example, fibrin. Okay. In histology, vessel walls contain eosinophilic layer of proteinaceous material. Okay. The vessel wall. So let's take this. So this is a vessel wall. This is where the black arrow is. Okay. Um, it contains eosinophilic layer of proteinaceous material. So it has a lot of proteins. Okay. And there you go. It's eosinophilic, just as it seems, and it's proteinaceous. So that was the fibrinoid necrosis. The very last type of necrosis is gangrenous. It's distal extremity, usually like the very distal extremities, and GI tract, and after chronic ischemia. That, well, basically the reason is chronic ischemia. So over here, it's a chronic ischemia, like a chronic decreased supply of blood and nutrients. That's why it first happens distally, because the blood cannot, like, takes a really longer time to get to the extremities into the GI tract. So that's gangrenous. It could be one of two types, either dry or wet. For the dry, that's when there is an ischemia, just like F. So if there is an ischemia or very cold, like extremely cold weather, for people, I don't know, climbing some mountains in the snow, and they like go into that very cold weather where their fingers don't get enough blood supply, they would develop dry ischemia. But if there is a super infection, like over this ischemia, there is a super infection, some other kind of infection, that's what gangrene. Okay, for the dry ischemia, or for the dry gangrene, that's because of ischemia, it would lead to coagulative necrosis. Over here we can see some coagulative necrosis. If it was a wet gangrene, which means there is a superinfection, then usually it's a liquefactive necrosis superimposed on the coagulative. So the main thing here, like the main type of necrosis in the gangrenous is coagulative, okay? If it's just ischemia, then it's just a coagulative. If there is like some other kind of infection because of that gangrene, that means there is a liquefactive necrosis in addition to the basic coagulative necrosis. And I guess that's it for now.